Persistent tracheocutaneous fistula, or TCF, is a condition where, after tracheostomy decannulation, an opening remains between the trachea and the skin. This fistula can vary in size. Small fistulas may cause issues due to the discharge of tracheal secretions, while larger fistulas might even function as an alternative airway if they don't close naturally. The incidence of TCF is significant, ranging from 19% to 42% across different studies. Several factors contribute to the likelihood of developing TCF. Younger patients at the time of their initial tracheostomy are at a higher risk, as well as those who had a tracheostomy for an extended period. Additionally, the risk increases if there's an obstruction above the level of the stoma, such as inadequate reconstruction in cases of subglottic stenosis. There has been some debate about whether sutures at the stoma site, often used to help the stoma heal more naturally, increase the likelihood of TCF. However, larger studies with sample sizes of more than 100 cases have generally disproven this, indicating that sutures alone don't necessarily lead to fistula formation. When it comes to closing a persistent TCF, thorough assessment of the upper airway is essential. Doctors must ensure that any obstructions or granulation tissue within the trachea are identified and addressed, as these can contribute to the formation or persistence of the fistula. If any obstructions remain, the fistula might continue to act as an accessory airway, undermining the closure attempt. There are two main surgical approaches to close a TCF: secondary closure and primary closure. Secondary closure involves removing the skin lining the tracheostome tract or using techniques like diathermy, coblation, or chemicals, such as trichloroacetic acid, to scar and seal the tract. This approach is also referred to as closure by secondary intention, as it relies on natural scarring to create a solid closure. Primary closure is a more direct approach. The surgeon dissects the tract down to the level of the trachea, closes it with sutures, and repositions the strap muscles to fill in any cosmetic defects left by the decannulation. The surrounding scarred skin can also be excised in a horizontal fusiform incision for a more cosmetically appealing result. The surgeon often leaves a drain in the wound for 24 hours to prevent air leaks, which can lead to complications like surgical emphysema and pneumomediastinum. Due to increased risks associated with primary closure, such as air leaks or other post-surgical complications, some experts advocate secondary closure as a preferred technique. Research reviews also tend to support this approach due to its lower risk profile. In conclusion, TCF management is tailored to the patient, and closure techniques are selected based on the fistula's characteristics and the patient's overall condition. These options allow surgeons to effectively close the fistula, minimizing risks and enhancing recovery.